Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have an important lecture, Premature Ovarian Insufficiency. So, what we want to know about it? After going through an introduction, you should know the definition of premature ovarian insufficiency, some terms, epidemiology, causes of premature ovarian insufficiency, clinical manifestations, diagnosis, and lastly, treatment. Let us go on. First of all, you should know that the number of oocytes in human ovary changing during female life, starting from the fetal life till birth, till puberty, childbearing age, and menopause. Okay? So, the number of oocytes in human ovaries is determined during fetal life and progressively decreased throughout the female reproductive lifespan. Okay, what is the maximum number of oocytes? 6 to 7 million, approximately 20 weeks gestational age. So while the fetus in utero at the gestational age of 20 weeks, this is the maximum number of oocytes in the ovary, 6 to 7 million. Then gradually decreases to approximately 1 to 2 million at birth. So at birth, the number of oocytes is 1 to 2 million. Then become 300,000 up to 500,000 at puberty. Okay, so at puberty, 300,000 up to 500,000 oocytes. From puberty to the age of 51, there is a progressive age-related decline in both quality and number, which is responsible to decrease fecundity. Okay, while the reduction in oocyte quantity and the quality with the advanced age, typically in the mid-40s, are a normal physiologic occurrence termed diminished ovarian reserve. But the problem is some women experience this diminished ovarian reserve early and they become prematurely infertile. So, what is the definition of premature ovarian insufficiency? Premature ovarian insufficiency denotes the partial or total loss of normal ovarian function before 40 years of age. The triad that define premature ovarian insufficiency encompasses oligomenorrhea or amenorrhea, elevated serum gonadotropin levels above 40 milli-international unit per milli, and diminished serum estrogen levels. Please look to some different terms. In the past, they use premature ovarian failure to talk about our subject today, or premature menopause. This is historical. So this name of depression of the ovarian function or suppression of ovarian function or follicles change it to become premature ovarian insufficiency. This is the most recent one. The term premature ovarian insufficiency was adopted by the American Consensus Meeting and by the European Society of Human Reproduction and Embryology. Okay? Why we replaced the name to become premature ovarian insufficiency? Because this term is now more favored due to the potential persistence of impaired ovarian function over varying durations. What about epidemiology? The premature ovarian insufficiency affects approximately 1% of women under the age of 40 years, while it is 0.1% of women under 30 years old. So it is commoner at if it happens under the age of 40 years old. 1% constitutes 1% of women under 40 years old, but 0.1% of women under 30 years old. You should know also that premature ovarian insufficiency incidence also depend on ethnicity. You will find in Caucasian it constitutes 1%, while in African American 1.4, and also 1.4 in Hispanic, but 0.5% in Chinese women, and 0.1% in Japanese women. This is the lowest incidence in premature ovarian insufficiency in Japanese women, 0.1%. What about histological examination of ovaries from premature ovarian insufficiency? Histological examination of ovaries show either complete loss of ovarian follicles or persistence of more or less abundant follicles. And the latter represent 40% of premature ovarian insufficiency patients and is in agreement with ultrasound studies that have demonstrated residual follicular structures in 41 up to 60% of patients with premature ovarian insufficiency. What are the causes of premature ovarian insufficiency? Multiple causes, but the commonest one is the idiopathic. It constitutes 75%, but recently they discovered some genetic problem related to premature ovarian insufficiency was considered as idiopathic. So the percentage decreased to somewhat, but still idiopathic is the commonest cause, and it is diagnosed only after exclusion of other causes. What else are the causes of premature ovarian insufficiency? Chromosomal and genetic factors, 6 chromosome abnormalities, for example, Turner syndrome. You know, in Turner syndrome, there is 45 X chromosomes. There is missing one X chromosome. Also, in autosomal chromosomal abnormalities, autoimmune ovarian damage as what's happening in autoimmune polyendocrine syndrome. Some infectious causes, specifically mumps or oophorytis. Mumps can be affecting the gonads, causing arthritis and the damage of the ovary. Iatrogenic causes like chemotherapy, radiotherapy, and ovarian surgery causing damage to the ovary. Lifestyle factor like alcohol consumption, smoking, and some chemicals, exposure. Environmental causes like endocrine disrupting chemicals, as bisphenol A. Human papilloma virus vaccination reported in a few cases to cause premature ovarian insufficiency. By the way, coronavirus disease, COVID-19, you remember? Also, coronavirus disease infection and vaccination also reported in some cases. So premature ovarian insufficiency can happen with this human papillomavirus or coronavirus disease, human papillomavirus vaccination, and the coronavirus disease infection and vaccination. Okay? But this is some reported cases need more studies. Okay, let us go to the clinical manifestation of premature ovarian insufficiency. Menstrual cycle disturbance, oligomenorrhea or amenorrhea is the most common initial symptom of premature ovarian insufficiency, with some patients consulting a physician for primary amenorrhea. Hypoestrogenism, which results from premature ovarian insufficiency, decreased production of estrogen from the ovary, causing vasomotor symptoms simulating that of mature menopause, like hot flashes, night sweats, vaginal dryness, dyspareunia, moody changes, and poor concentration. Patients exhibit impaired cognitive function and are at higher risk of developing dementia and Parkinson disease. Also, patient has an elevated risk of cardiovascular disease and the early onset of coronary heart disease, leading to increased mortality than those with normal natural menopause. Estrogen deficiency has a detrimental effect on bone health, decreasing the bone mass density and increasing the risk of fracture later in life. This is very important point. Of course, infertility could be a problem. What about infertility and the pregnancy in patients with premature ovarian insufficiency? Okay, you should know that patients with premature ovarian insufficiency generally show 5 to 10% natural conception rate. Really, it can happen, yeah, but 5 to 10% natural conception rate. Spontaneous pregnancy in idiopathic premature ovarian insufficiency or chemotherapy-induced premature ovarian insufficiency doesn't show significant differences in obstetric or neonatal complications. And this is good news. But the bad news that pelvic irradiation causing premature ovarian insufficiency, if a pregnancy happens, there is risk of miscarriage, premature birth, low birth weight, stillbirth, postpartum bleeding, and neonatal hemorrhage in pregnant women. Okay, let us go to the diagnosis of premature ovarian insufficiency. Two important items should be present. Oligomenorrhea or amenorrhea persists for more than 4 months. Serum level of follicle stimulating hormone on at least 2 consecutive tests exceed 40 milli international unit per milli at 4 weeks interval in women aged under 40 years. Okay, so the patient should fulfill this criteria. Oligomenorrhea or amenorrhea more than 4 months. If I measure serum FSH, I'll find that more than 40 milli international unit per minute. And I repeat it after 4 to 6 weeks, I'll find it also above 40 milli international unit per minute. Estrogen deficiency causes distressing symptoms like hot flashes, night sweats, sleep disruption, vaginal dryness, anxiety and depression. Should I do test for anti-Mullerian hormone as a routine? No, it is not a routinely done to diagnose premature ovarian insufficiency, but may have a rule when the diagnosis of premature ovarian insufficiency is inconclusive. So don't ask for serum anti-Mullerian hormone except if the diagnosis is inconclusive, so do it. You will find it, of course, very low. What is the treatment of premature ovarian insufficiency? The treatment plan determined based on the cause of premature ovarian insufficiency, and if it can be prevented, it is better. So to save the ovaries before occurrence of premature ovarian insufficiency. So the treatment depends on the cause, the severity of symptoms, family heredity, genetic abnormalities, and underlying conditions. What about conventional treatment? Treatment of premature ovarian insufficiency involves lifestyle modification and bone health, symptom alleviation, hormone replacement therapy until natural menopause around the age of 50 years. HRT is not recommended in women with history of breast and ovarian cancer. You should know this. It is contraindicated in patients with history of breast or ovarian cancer. Psychological support, of course, is very important. Counseling for contraception and fertility. So what about lifestyle modification and bone health? Please advise the woman regarding lifestyle modification and bone health. And this should include information on a balanced diet, adequate calcium and vitamin D, smoking cessation, as well as avoidance of excessive alcohol intake, encourage exercise. What about hormone replacement therapy? By the way, I have a previous lecture about menopause and hormone replacement therapy in details. You can find it on my YouTube channel. Okay, you should know that appropriate physiologic estrogen and progestin therapy is regarded as the conventional management of premature ovarian insufficiency. Physiological estrogen levels can be achieved with oral micronized estradiol 1 up to 2 milligrams daily or conjugated equine estrogen, which is taken from the urine of pregnant horse. This conjugated equine estrogen in a dose 0.625 up to 1.25 milligram daily, or transdermal estrogen regimen 0.1 milligram daily. It is said in some reports that 17 beta estradiol is better choice to prevent any problem regarding the memory, verbal cognition, and so on. Decrease occurrence of Alzheimer. Some report saying that. Okay, how can the woman take hormone replacement therapy? Either continuous or cyclic progesterone with estrogen in women having uterus. But if the woman did hysterectomy before, estrogen alone is quite enough. But if the uterus is present, we're trying to avoid endometrial carcinoma, or endometrial hyperplasia, so we give progestogen to antagonize the effect of estrogen on endometrium. This progestogen is given either continuous from day one and through the month with estrogen, or cyclic progesterone. What does it mean? I'll give progestogen in a cyclic schedule 12 to 14 days every month. Okay, so I'll start with estrogen and continue with the same dose of estrogen all over the month, but at day 15 or 14, for example, I'll start 14 days of progestogen. Which type of progestogen? Micronized progesterone 200 milligram daily, or medroxyprogesterone acetate 10 milligram daily. Any one of them can be used in this dose. Okay, for 12 or 14 days in a month. You should know that systemic sex steroid hormone replacement is effective for the management of menopausal symptoms in women with premature ovarian insufficiency, and topical estrogen preparations are effective for the management of symptoms related to urogenital atrophy. There is limited evidence assessing the optimal regimen, dose, or route of administration of hormone replacement in women with premature ovarian insufficiency, as mentioned by the British Menopause Society. Sex steroid hormone replacement should be considered the preferred choice of treatment for the prevention and the management of osteoporosis in women with premature ovarian insufficiency. And as I said before, if there is no contraindication for hormone replacement therapy, I can continue up to the age of 50 so long as there is no complication and there is no contraindication. Why the age of 50? Because this is the age of menopause, the age of natural menopause. Okay? Biphosphonates. You know that biphosphonates is used to manage osteoporosis shouldn't be first-line treatment for the management of osteoporosis in women with premature ovarian insufficiency and should only be considered after discussion with an osteoporosis specialist. But if there is contraindication for sex steroid hormone replacement, you can, of course, go to the second-line treatment, biphosphonates, to manage osteoporosis together with calcium. Assessment of bone mineral density using DEXA should be considered at time of diagnosis of premature ovarian insufficiency. You should know what the quality of this bone is. There is osteopenia, osteoporosis before you start treatment. So you should have the baseline investigation like DEXA result when you diagnose premature ovarian insufficiency. The frequency to repeat bone density assessment should be guided by the woman's risk for developing osteoporosis, and the consideration should be given to repeat bone mineral density assessment in women with osteoporosis within 2 to 3 years of the diagnosis. And this is a recommendation also of British Menopausal Society. What about treatment of infertility? Really, it is a challenge. But you should know that it is reported that only a small percentage, about 5 to 10% of patients, are known to conceive naturally. Okay? So it can happen? Yes, it can happen naturally in 5 to 10% of patients. Several trials of infertility treatment exist, including ovulation induction, use of gonadotropin or gonadotropin-releasing hormone agonist, estrogen priming, danazol, and the corticosteroid. But the bad news, none of these methods has demonstrated a clear advantage in increasing pregnancy rate or improving fertility. And many studies are running in this era about management of infertility in premature ovarian insufficiency, but doesn't prove any successful result up till now, like platelet transfusion, plasma with platelet injection in the ovary, but doesn't prove any successful result up to now. A recent retrospective study reported promising outcome of in vitro fertilization and frozen embryo transfer in patients with premature ovarian insufficiency. Patients who underwent repetitive oocyte retrieval to obtain autologous viable embryos showed a cumulative clinical pregnancy rate and the cumulative live birth rate comparable to those in an age-matched normal control group. It is remarkable that this positive outcome is limited to women with premature ovarian insufficiency with a substantial number of follicles, typically seen in cases caused by autoimmunity or in those diagnosed at an early age. What about fertility preservation techniques? Fertility preservation technique like oocyte or embryo cryopreservation or ovarian tissue cryopreservation are unlikely to be successful in women with established premature ovarian insufficiency. However, fertility preservation and in particular, oocyte or embryo cryopreservation would be suitable option for women at risk of premature ovarian insufficiency, including those due to undergoing chemotherapy or radiotherapy that may diminish their ovarian function, or women with a strong family history of premature ovarian insufficiency. So you can use fertility preservation technique like oocyte cryopreservation or embryo cryopreservation, in which patients and those at high risk for occurrence of premature ovarian insufficiency, like those with family history, for example, or those exposed to chemotherapy, will be exposed to radiotherapy and chemotherapy for management of certain malignancies or disease. So you can do it before occurrence of chemotherapy or radiotherapy. So fertility preservation technique to prevent or as a prophylactic in high risk patient for premature ovarian insufficiency. What about stem cell therapy in premature ovarian insufficiency? So what is stem cells? Stem cells are undifferentiated or partially differentiated cells derived from embryos or adult tissue. They possess the unique ability to self-renew and differentiate into various cell types. They are broadly categorized as embryonic stem cell or adult stem cells and induced pluripotent stem cells. Mesenchymal stem cell constitute specific subset of adult stem cells that originate from various tissues such as bone marrow, adipose tissue, menstrual blood, umbilical cord, amniotic fluid, amniotic membrane, placenta, and endometrium. The medical application of stem cell, known as stem cell therapy, leverages their inherent properties to restore function in damaged organs. Specifically, stem cell therapy holds promise for the regeneration of ovarian function and oocyte in patients with premature ovarian insufficiency. So research is now running about stem cell in different fields, one of them premature ovarian insufficiency. But up till now, I cannot say there is results that we can depend on. The researches are running and you are waiting for the results and recommendation about stem cell therapy. So what about contraception used in patients with premature ovarian insufficiency? As I said before, spontaneous pregnancy may happen in 5 to 10%. You remember? And also you should know that sporadic ovulation may occur in 23% up to 75% of women with premature ovarian insufficiency. And the recovery of the menstrual cycle is observed in 25 up to 50% of such patients. So, if the patient don't ask for being pregnant, she has already children, or she don't need any more of children or need to be pregnant, you should prescribe for her contraceptive method to prevent pregnancy because she don't need any pregnancy. Okay? A proper contraception should be provided to patients with premature ovarian insufficiency if they don't desire pregnancy. So what type of contraception? Levonorgestrel intrauterine releasing system with estrogen replacement could be a good choice if you are giving hormone replacement therapy for this patient, the form of estrogen alone replacement therapy. You can use Mirena or levonorgestrel releasing intrauterine system, releasing 20 microgram per day levonorgestrel intrauterine. Okay? What else can be used? Barrier methods can be advised, like male condom or vaginal diaphragm or vaginal condom, and so on. What about combined oral contraceptives? Maybe an effective alternative to hormone replacement therapy with the additional contraceptive benefit in a healthy younger woman. And this is recommended by the North American Menopause Society guideline published in 2022. So I can use the combined oral contraceptive for two targets. One as a hormone replacement therapy and the other one as a contraceptive method. Okay? So either I give the patient levonorgestrel releasing intrauterine device together with estrogen replacement therapy, or using combined oral contraceptives to give me two benefits, one as hormone replacement therapy and one as a contraceptive method. This is some reference for those who wanna read more. This is my published book on Amazon in this picture. The last one recently published on Amazon is Update in Obstetrics and Gynecology. You can find it through the link in red here. The other box, textbook of obstetric, textbook gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy and the gynecologic oncology. All 7 books belong to me. You can find it through going to Amazon through this link, and I'll write it in a comment, this link in red. If you are searching for menopause and the hormone replacement therapy and the other lecture in gynae and obstetrics and the ask station multiple choice question, it is free, available on YouTube channel belonging to me through this link. I write link on a comment also, so to be easy for you. And the last one, Blogspot, is a scientific site, also belongs to me. I hope it is helpful for you. Thank you, everybody. Wishing you all the best.